The Parkinson's Podcast is brought to you by the Davis Phinney Foundation and brings you the stories, wisdom, and expertise of people living with Parkinson's, care partners, and Parkinson's professionals. In this second episode of our Neuropsychology of Parkinson's series, Connie Carpenter-Phinney and Dr. Mark Mapstone take a close look at what happens during a neuropsychological evaluation. They explore when and why someone might be referred, what the testing experience is like, and how the results can help guide care and communication. If you find our podcast and other resources helpful, please consider donating to support our work by visiting dpf.org/donate. That's dpf.org/donate.
I think what we should talk about next in this exploration of what it means to be a neuropsychologist and how you function with people with Parkinson's is what an actual office visit looks like. Why and how do people get referred to you that have Parkinson's? And when they do come, what does that look like? And I will backtrack that just a little bit by saying that I know it's not easy for many of us with our person with Parkinson's to get them a consult with a neuropsychologist. There's quite often that the movement disorder doc thinks they've got it covered. And yet the care partner or the person with Parkinson's is saying, I would like to know more. I want to understand more about where I'm at so that I can do something about it. So I'm curious for you in your practice, how do people find you?
I would start with, first, it can be a real challenge. There are relatively few of them in North America, roughly about 3,000 or so board certified, I believe, is the number these days. And so it can be a challenge to find us. I mean, we're concentrated around large academic medical centers, typically in larger cities. So if you're out there in a rural community or in places that's not highly populated, it can be a challenge to get appointments to see us. So how do people get to us? It's largely a referral base. We typically practice in association with other subspecialty physicians who will make referrals to us. So this might be your movement disorders doctor. It might be a general practitioner who is aware of our presence and can make referrals out when needed. Some of us specialize in movement disorders, which it's clinical neuropsychology just for movement disorders. And those are even a rarer breed. More of us are general practitioners where we see things related to other neurodegenerative conditions like Alzheimer's disease. We might see after traumatic brain injury or stroke, those certain conditions where we can help evaluate what the cognitive consequences of the condition or disease are. And we can help with treatment planning. We can make a diagnosis. We can help with rehabilitation sometimes. We are typically the person that a movement disorders doc or a general practitioner might refer to for subspecialty evaluation in cognition when there's a concern. You know, often we're referred to when somebody notices something's wrong and need input and advice on what is happening to this person. Are they experiencing challenges and what are they? Can we define them and what can we do about them?
So let's say I've noticed something about my person with Parkinson's and my doctor has agreed to make the referral. On the first meeting, would they come alone or would they come with a care partner? And what would a first meeting look like?
So we all practice differently. I almost always start with a person with Parkinson's and the informant, somebody who can corroborate what's going on. And the reason for that is not that we don't trust the person with Parkinson's disease, not that we care more about what someone else is seeing, the spouse or the child or something like that. It's more that sometimes in some of these conditions, our own awareness of what's going on in our own behavior is limited by the condition itself. And this has a fancy term called anosognosia, which is the inability to recognize one's own, you don't know what's even going on with yourself. And so my asking a person with Parkinson's who has a mild form of anosognosia about their own behavior is not going to get me very far because they're not going to tell me anything, or they're going to tell me very limited amounts of information. So it's really important for me to hear from another set of eyes, somebody else who's got eyes on the person and can tell me, well, they are having trouble. You know, I hate to generalize, but lots of time men of a certain age do not want to admit to having particular kinds of problems. They might say, I'm very competent. I have no problems with my memory. I remember everything that I need to. And then you get the wife in the other room and you talk to her and she says, wow, he's really starting to forget X, Y, and Z. And it turns out that it is true that he's just not admitting to the things that are going on. And it's not always just men, but I'm being stereotyped here. But I think it really helps to have that other set of eyes and to get information from a corroborator. As a matter of fact, it's definitional, meaning it's part of a definition for something called mild cognitive impairment and dementia, that those symptoms are not only brought up by the patient, but also somebody else has to witness them as well.
What happens in a case where a person with Parkinson's does not have a close care partner, but they've noticed that things have changed and they come in on their own? I mean, obviously you're not going to turn them away, but it's going to be more difficult for you, isn't it, to understand their situation?
It can be, but I think the basic principle, certainly that I always operate under and most of us do, is that we trust our patients. If our patient is coming in and telling us something, I believe what my patient is telling me. Nobody knows what one is going through other than oneself. You're the best person, except in those limited cases where this thing called anosognosia exists, where you actually can't recognize what's going on with yourself. Most of the time, my patients are going to tell me exactly what's wrong, and they're going to tell me way before anybody else notices it. They're going to tell you, I am forgetting things, I'm losing things, even when the spouse doesn't recognize it yet, or the child doesn't recognize it yet. The first and foremost, the policy is to trust your patients. They're going to tell you what's up. And if you listen carefully and you're really listening, you're going to get the real story. It does help to have that other bit of information because you can get some, additional info on what might be going on.
I think it's also common, I would guess it's common, although you'll have to tell me, if denial is at play here, right? Because I think that, so often, especially as regards our cognition, we don't want to admit that it's failing. And so I would think that would be, part of the situation at hand in order to kind of nudge someone to walk through that door and see you. But it's not the case, is it, that all people with Parkinson's should consult? Or is it the case that all people with Parkinson's should consult a neuropsychologist?
So I think there's value to a neuropsych consultation for most patients with Parkinson's at some point during their journey. And sometimes that's earlier than others. And there's a couple of reasons why one might want to get in to see a neuropsychologist earlier, and that is to establish a baseline, particularly if you're anticipating that there are some therapeutic options that might affect cognition. You might want to get a baseline of what things look like before you start any sort of therapy that might impact your cognition. Some of the drugs that we know for Parkinson's disease that can affect cognition can affect certain behaviors like obsessive or compulsive behaviors. Certain of the medicines can induce OCD-like behaviors or obsessions and compulsions. And it would be a good idea to have an idea at baseline whether those things are there or not in order to see whether the medication actually caused that change or not. There may be reasons why you wouldn't want to go on a particular medication based on a baseline cognitive evaluation, because you might be more susceptible to having cognitive problems down the line if you try a particular drug or a particular surgical procedure, for example. This might be deep brain stimulation or some of the cell or gene therapies that are now being introduced. So in those situations, a cognitive evaluation, even when you're not having cognitive symptoms, can be very useful for predicting and also documenting whether anything happens with treatment. I mean, sometimes things change when you introduce a new drug and you can get them off of that drug and then the cognition will go back to the baseline.
Well, what I wanted to follow up with that too is that quite often in the doctor's office, whether it's your general practitioner or your neurologist, might say, well, we can run a short cognitive evaluation. But that's not what you're talking about here, right? You're talking about much more complex assessment. And could you talk a little bit about what that looks like? And if there are reasons why you need that versus just the simple cognitive evaluation?
So the simple cognitive evaluation that you're referring to is usually a screening tool, often used as something called the MoCA, or the Montreal Cognitive Assessment. And it's something that most movement disorders neurologists feel comfortable with and can do in their clinic. It takes about 10 or 15 minutes to administer, and it gives you it's a screening measure. It doesn't give you details, but it kind of gives you a broad idea of how someone's kind of doing. Your movement disorders neurologist might do this, or a practitioner might do this just to keep an eye on things. But if you score in a range that's worrisome, they might refer you to a more detailed cognitive assessment than a neuropsychologist might do. And for us, when I do a neuropsych assessment on somebody with, for example, Parkinson's disease, it might take me about an hour and a half to do. It consists of a very detailed clinical history. I want to know how the person is doing. I want to know lots of information about them because they are my best source of information about what's going on within them. I can see a tremor. That's not what you need this for. I need to sort out the difference between affect and mood. So I can tell you if you look depressed, but I don't know if you are depressed. Only you know if you are depressed. And you tell me, you being the patient, tell me that you feel sad or despondent or down in blue for greater than 2 weeks at a time, in which you don't feel like you can get out of things and things are hopeless and helpless. That is mood. That's something that only you can report as an individual. I can look at your affect and see what you project to me on the outward side, but that's just a manifestation of what's going on inside, and you can hide that. You can exaggerate that very, very well. So your mood is an internal state that only the individual can report. I need to get a hold of that.
I think the other thing that's difficult with a person with Parkinson's is the facial masking. And so the affect is more difficult. It takes some time to understand that. But after 90 minutes, the person with Parkinson's is pretty exhausted, aren't they, in this kind of situation?
Absolutely. So we need to be cautious about how far we push or how long we push somebody who's got reduced energy levels. But it's also hard to keep up a facade in front of a doctor for 90 minutes. You spend a 15-minute or 20-minute evaluation with your movement disorders neurologist, you can kind of bluff your way through that if you're motivated to do so. And so there's a challenge sometimes about actually seeing what's really there. If I get time to spend with a patient in the room for 2 hours and I know what I'm doing and I have the experience, I'm going to get to the bottom of it. I'm going to see what's really there. It's really hard to keep that up over that amount of time. And that's one of the benefits of having a cognitive evaluation. You can really get to the true source of what's going on.
And so during that 90 minutes or 2 hours that you're with the patient, would the care partner be in there the whole time, or would there be points in time where you would separate out and just be one-on-one? And can this be done virtually? Can it be done on a Zoom call?
Yes, absolutely. So to answer your first question, the initial clinical interview would take place maybe about 20 minutes worth of time, in which I would want the care partner to be with the patient with me, because I want to hear from both sources. And then I'm going to ask the care partner to leave the room, and I'm going to do the actual cognitive evaluation with the patient directly. I don't want the care partner in the room during that time, because I don't want to embarrass the patient if he or she can't do things that I'm asking them to do. I don't want the care partner to help the patient, which we frequently see. There's advice giving and giving little hints and cues. I don't want that to happen. So it's best if the care partner is out of the room and it's just me and the patient, and most neuropsychologists are going to do it that way. Then we typically bring the care partner back into the room and we debrief, and I go over everything that happened during the cognitive evaluation. That's usually about an hour's worth of testing, about a half an hour's worth of interview, and about however long we need afterwards to debrief and sort of say, here's what I think's going on, here's what the tests show, here's where I think our next steps are for you and your care plan.
And so just to be clear, you could do that virtually.
Yes, one of the benefits of COVID, and there weren't many, but one of them is that we've developed in the field of neuropsychology fairly robust approaches now to remote assessment. There are still some limitations about the ability to do this across state lines. So you may need to find a neuropsychologist within your state to do a virtual assessment. But we are developing now some fairly robust ways to do cognitive assessments while you're sitting at home on your computer, and I'm sitting in my office, on the other side of the state.
That's so important, because if someone has to drive 2 hours to see you, they're going to be pretty tired by the time they get there. And not everyone's going to come in the night before and be able to, have a restful night or something, and you don't want to be tired coming into this. You do want to bring your best self. In terms of the debrief, and then that would include potentially different therapies or prescriptions. What's typical that comes out of these kind of assessments?
I'm going to give, in my immediate debrief, an off-the-cuff impression. I'm going to say, here's how you did, and here's what I think it means. All of that's going to be under the sort of rule that I'm going to go back and I'm going to properly score everything. It takes time to score these tests. And so I'll dictate a note afterwards, or a report that will come afterwards. But I want to give the patient immediate feedback that day. But the goal is to come up with a treatment plan. And to say, what can we do about this? It's not just about, well, where are your deficits? Let me tell you how badly you did on X, Y, and Z. It's about, well, what do we do about this? And there are some medications, there are some circumstances associated with a movement disorder like Parkinson's that can improve your cognition. There's a class of drugs, for example, that can be used in people with Parkinson's disease and certain tremors called anticholinergics. And these are very bad for your memory. They're notorious for making you a little foggy. And if you're on an anticholinergic, to help control some of your tremor. They're not as commonly used these days, but if you happen to be on one, I can suggest, hey, I'm seeing some memory stuff here. Maybe we ought to think about getting with your movement disorders doctor and reducing the amount of that anticholinergic you're taking. Acetylcholine is another one of those neurotransmitters. It's not dopamine related, it's a different one, but it's involved in memory. So we can have recommendations like that. I should point out neuropsychologists, by and large, do not prescribe medicines. There are some of us who can be qualified to do so, but we are clinical psychologists. We have PhDs or PsyDs. We have doctorate level training, but we are not physicians. We are not MDs or DOs or nurse practitioners. So we do not prescribe. However, suffice to say, most of us know a lot about the medicines in our subspecialty areas. So if you're talking about Alzheimer's disease, I'm pretty good with the medicines that are there. I cannot make official recommendations about medicines, but I'll get with your doctor and say, hey, listen, here's what I see. You might want to think about doing this or try this other drug that has these different properties. So those are different things. It could be you're getting poor sleep. And you're telling me, I'm not sleeping well. I'm going to say, hey, you should really get a sleep evaluation. Maybe CPAP. Maybe you've got obstructive sleep apnea. And a CPAP machine is going to really help you, and it's going to bring your cognition back. You'll have better memory the next day when you sleep better. So those are the various sorts of things that we can talk about that can be directions for treatment and where to go to make things better on a day-to-day basis.
Does the recommendation for talk therapy come up often? I would think that would play more with depression, which of course depression plays heavily into cognition, right? And can be remedied either with medicine and or talk therapy.
That's actually an outcome that we can feel pretty good about having some impact on, is if we see evidence of mood disorder, either depression or anxiety, for example, or other things along the mood spectrum. Yes, talk therapy is definitely one of those things that we can recommend. And as clinical neuropsychologists, we are clinical psychologists first. We are trained in talk therapy. I do, not frequently, but I can do talk therapy. So we know exactly how this works. We know it works the best for individuals, and we can make recommendations. And in some cases, we can even do the talk therapy as neuropsychologists. I can say, it sounds like you're having some problems with guilt and shame. And, maybe a couple of sessions with me just sitting and talking about some things is going to help you kind of bring some of these issues out and we can move forward. Maybe you need to try a medication for it. And some of these medications work pretty well. So there are avenues. There are things we can do here. This is not a fait accompli where this is how it's going to happen to you. We do have agency over these things, and that's a really important thing for both the patient with Parkinson's disease and the care partner to know and to come away with.
Yeah, you're not just taking the test to prove that what you don't know.
Right.
You're coming in to be evaluated so that you can make change. And I do think, whenever I talk to movement disorder docs, and certainly when I talk to you, I know that, your motivation is to help people. And people with Parkinson's can see huge improvements based on lifestyle changes, medication changes, and just getting the right help. And it is hard to get. And to your point, it's hard to find one of you. But I think that, I'm hearing from this that just about everybody with Parkinson's should be asking their doctor for a referral to get a baseline if they don't already have one, because it will help them in their journey. And especially if they have a downturn, to be able to go back and reevaluate. Because is this pretty accurate across the number of years? If someone comes in today and then they come back in 5 years, they're typically using a similar instrument to be able to measure change?
We like to use the same tools over time so that we can compare apples to apples. So if I give you one sort of memory test at a baseline, then 3 or 4 years later, I'd like to use the same memory test. We want to try to avoid practice effects, which is you're learning of it just because you've had it before. But if you do have practice effects, that tells me that your memory is in pretty good shape if you remember it 3 years later. So in any event, we do like to use the same sorts of tests going forward, but I think it's highly beneficial. And most of the movement disorders neurologists that I know are the type of people who really value the information because they don't have the time to do it. They may be competent in doing some of these tests, but they don't have the time. Their schedules are set up in a way that they get 15, 30 minutes maybe with each patient each time, and that's just not enough time. Whereas we have the luxury of being able to sit back and take some time with you and really dig deep and really deeply phenotype you and understand who you are.
And then your follow-up is not only with the patient, but with the movement disorder doc. And that would be a written evaluation or typically a conversation on the phone?
It completely depends on how the clinics are structured. In integrated academic centers and movement disorder centers, a neuropsychologist works hand in hand in the same office building and the same clinic as the neurologist. They'll often sit and do a team meeting. So they see the morning patients, and then the movement disorders doc and the neuropsychologist get in the same room, have their lunch, and say, okay, I saw Mrs. Jones. Here's what I thought. Oh yeah, her depression's doing better. You might want to think about tapering back on the Lexapro. And, we do that and we take notes and we do those in integrated clinics. When it's a stand-alone clinic for a neuropsychologist, I would dictate a note that would go into the patient's record. And then the doctor would see that next time the patient comes in or before, and will likely give me a call and say, I saw that you saw Mrs. Jones 3 weeks ago. Can you just give me a quick update on what you thought? I see you noticed this is getting a little bit worse. What do you think we ought to do about that? So there's communication back and forth. Yes, for sure.
Appreciate the team approach for sure. Well, I think that answers a lot of questions about what a consult would yield and why it's so important for all of our people with Parkinson's to try to find someone that can do this type of testing and someone that they can work with, even knowing it may take you 6 months or a year to get an appointment. Things like this aren't typically urgent, but they are important, right? Like to go down that road and get that advice, because cognition is such a huge part of our life, to have good quality of life, but then also because we can work on it.
Absolutely. And, in people with Parkinson's disease and other movement disorders, it's counterintuitive, but it's typically not the movement issues that lead to the loss of functional capacity or the ability to live on one's own independently. It's the cognitive and behavioral stuff that makes those changes more challenging. When you're forgetting to do the important things to keep yourself safe, it turns out those are the things that motivate people to make changes to preserve independence. It's not the movement stuff by and large. So these are important things to keep an eye on, because these are the things that are closely tied with our ability to live our independent lives. And you need to be an advocate for you or your person with Parkinson's disease. If your movement disorders neurologist doesn't see this of value, I think it's important to raise it with that person and say, I really would like to do this. Can you help me find a way to get this done? If you feel like it's something you want.
Yeah, and keep pushing. There's just so much to deal with sometimes that we don't know where to start. And I think if we can just sort of parse it out into different categories and see how we're doing. And to your point, the movement one is the one that seems the most obvious, but the cognition and the emotional health is the hard part. And if you don't manage that, it's harder to keep a team around you, because you drive people away. And I think that's important too.
Absolutely. And if I could make a shameless plug for the foundation, you put out a great resource, a book for living with Parkinson's disease. I think it's such a wonderful, timely, you update it every couple of years so that it's got all the most recent information. It's a wonderful resource for how to handle the challenges ahead and how to handle them both as a person with Parkinson's disease, but also as a care partner and a family member in a community. And I think that is a great free resource. I believe it's still free, right?
Oh, yeah. Thank you for plugging that. It's available to anyone who needs it, really. And we call it Every Victory Counts, kind of after Davis's ethos as well, which is, the fact that the victories are hard fought with Parkinson's, and the victories are just, experiencing quality of life, and our emotional health is so important. So in terms of getting a referral, just a few more little tidbits that might help out here, or websites that you would direct people to. What's the best advice for finding care?
What I would advise is you look for a neuropsychologist who is fellowship trained in neuropsychology. This is somebody who has finished their PhD, and then they go on and they do 2 years of prescribed training in clinical neuropsychology. And it's often during that training in which they start to work with a subspecialty area like movement disorders or Alzheimer's disorders or traumatic brain injury. Those are the people that are going to be very competent and able to handle and most adequately be able to handle the things that are relevant to your person with Parkinson's. So I would look for a fellowship trained neuropsychologist. Many of them are now board certified. They have a designation after their PhD. There's a couple other letters afterwards. Those are going to be the most qualified, highest trained, certified folks. They're pretty rare, but if you can find one near you, that's probably where you're going to get your best. And if you Google clinical neuropsychologist board certified in my area or whatever major metro you're near or whatever, you should hit some of them.
Okay. Yeah, that's important to know. And I do think, we talk about this all the time, that it takes a team to help manage all the many symptoms of a person with Parkinson's. And you should consider that a neuropsychologist and a psychologist could be a very valuable addition to your team. So thank you so much for that in-depth information. I think it's super helpful. It's been informative for me, so I want to thank you for that.
Thank you for listening to this episode of the Parkinson's Podcast. Understanding the role of neuropsychology in Parkinson's care can lead to clearer answers, better support, and more confident decision-making. If you find our podcast and other resources helpful, please consider donating to support our work by visiting dpf.org/donate. That's dpf.org/donate. This content includes information, insights, and opinions from our Parkinson's community. The views expressed are those of individual participants and do not constitute medical advice. This content is not intended to substitute for the guidance, advice, or recommendations of your personal healthcare providers.